I'm one of those healthcare providers who inflict that pain. I'm a pediatric anesthesiologist by training, and Christine Chambers is a longtime friend and colleague. And, you know, I've just seen how the social media has had a huge impact in what she's done. So, but that was just an amazing presentation. My task today is really to introduce the global health section of this. And, you know, I'm often intrigued about why people think that global health is actually a segment of a focus of what we actually do in research. And I really haven't met any researcher who didn't want their research to have a global impact. And certainly from my personal experience, I think that that's what I want to have, is to have a global impact. And I think that the panel that we have today is going to show you how we can have that impact and why we should have that impact. And that impact should happen because, first of all, we live in this global context. We don't live in this little isolation of this province, and diseases don't know boundaries. But also, more importantly, is that a lot of the lessons that we learn globally have huge application to what we need to do locally. So, with no further introduction, I would like to introduce our first speaker, which is Kalysha Collson, who's recently defended her MSc thesis at Simon Fraser University, and she's going to come talk to us a little bit about gender, power, sexual decision-making among youth, particularly in South Africa. Thank you very much.
This is the thing? Okay. Thanks, everyone. I'm extremely honored to be here today amongst all of these amazing women researchers. Like Mark mentioned, I'm just recently graduated, or I haven't even graduated yet. I just defended my master's thesis a couple weeks ago, and I've been working at Simon Fraser University and the Center for Excellence in HIV/AIDS with my committee, Dr. Angela Kaida, Dr. Robert Hogg, and Dr. Carrie Miller. Angela Kaida was actually supposed to give this talk today, and she sends her regards and apologizes for not being able to be here today. She's actually on her way right now to South Africa to meet with the Minister of Health there and with our partners at the Perinatal HIV Research Unit in Soweto and the Maternal, Adolescent, and Child Health Research Unit in Durban, where I had the opportunity to spend a few months this last summer working on an adolescent sexual and reproductive health study there. So I'm really, again, honored to present to you some of my research findings from my master's thesis today. But I first just want to acknowledge that this work really could not have been done without the voices of all the young people who have and continue to participate in this research. And my interest in adolescent health dates back quite a while. I've worked in the front line with Indigenous youth here in Vancouver, and this topic around women's mental health today really touches home to me as I've worked, as I mentioned earlier in one of my questions, with women living with mental health issues in Vancouver for the last 7 years. So thank you all for all of the work that you've done. On a global scale, we know that adolescents, particularly in developing countries, represent a large proportion of the demographic, and this is quite different than what we see in Canada. And in places like Sub-Saharan Africa, by 2020, the youth population in Sub-Saharan Africa will have doubled from the start of the HIV epidemic. And some of this youth bulge is largely due to some of the successes that we've seen with the Millennium Development Goals, where we've seen a reduction in child mortality, as well as increases in fertility rates. So what this means, particularly in areas like Sub-Saharan Africa, is today the largest number of young women are entering an age where they are most at risk for HIV infection. And also, adolescence is a very transformative time, informative time, where we see the formations of mental health, of sexual relationships, of all these things kind of underpinning well-being across the life course. And particularly adolescents within developing countries like Sub-Saharan Africa, where heterosexual intercourse is the main form of HIV transmission, young people face disproportionate burdens to HIV infection, as well as other infectious diseases and sexual reproductive health outcomes. So if we're going to meet large targets, like we have this target to end AIDS by 2030 and some of the new Sustainable Development Goals, we really need to focus on young people within these priority settings. And within Sub-Saharan Africa, we see there's a really highly gendered epidemic. that is particularly prevalent in countries like South Africa, where on a weekly basis, young women experience new infection rates 3 to 4 times higher than young men their own age. And within South Africa, this is important, as South Africa is home to the highest absolute number of people living with HIV globally. So today, about 6 million people are living with HIV in South Africa. And this is influenced by a number of legacies of colonialism and apartheid, which have influenced the context in which HIV can easily spread, including extremely high wealth inequities between white and black South Africans, high rates of migrant work, unemployment, and this has been shown in research to influence patriarchal norms of masculinity that influence unequal relationship power dynamics for young women where they're unable or less able to negotiate safe sex strategies. So despite this gendered epidemic and the high sustained prevalence of HIV infection amongst young women in South Africa, we have the main prevention mechanism that we continue to promote is the male condom. And sorry, I have here, I don't know if you can see this, so the South African government has done a lot of work in promoting the male condom. This is a banana-scented condom that I brought back with me from South Africa, and just kind of showing that there are some creative ways that the government is trying to promote condom use, but I think there's kind of a lack of gendered research that looks at the need for this relationship between, in order to use condoms, we need access, so maybe we have some access, but also there's a need for an intention, knowledge, negotiation around condom use, and then of course condoms need to be used consistently and correctly. And so in Sub-Saharan Africa, there's been a number of studies and intervention projects that have tried to understand how intention leads to sexual behavior, including condom use, using a number of psychosocial theoretical frameworks, including this framework, Bandura's theory of self-efficacy, which essentially posits that if one has the necessary skills and awareness and self-efficacy or confidence to perform a given outcome, that they're more likely to do so. This research, however, has also been criticized in that it doesn't really address some of the larger social structural factors of sexual decision-making, and particularly the gendered epidemic that is occurring within places like South Africa. So my research sought to answer a couple of questions. So first, amongst adolescent men and women, what are the independent correlates of having high sexual self-efficacy, or SSE? And is high SSE independently associated with consistent condom use for men and women? So for this research, I used the Botschappella Adolescent Health Survey, which was a biobehavioral survey of 830 adolescents aged 14 to 19 that were living in Soweto, South Africa between 2010 and 12. And this was a collaboration between the Perinatal HIV Research Unit in Soweto and Simon Fraser University. The study team used community-level sampling to recruit participants from 41 formal and informal townships across different locations where youth frequent. And the survey was delivered by trained interviewers who are fluent in both English and Zulu, which is the most common language spoken in South Africa. And the development of the survey was done in collaboration with the study team and the Adolescent Community Advisory Board at the PHRU. And participants received 50 Rand, which is about $7 at the time to participate, and received free HIV voluntary testing and counseling. So for the main outcome for my first analysis and for the main exposure measure for my second analysis, we used this construct of sexual self-efficacy, which was a 6-item scale that measured participants' perceived confidence to use condoms, refuse unwanted sex, and communicate with their sexual partners. And the answers consisted of yes, probably yes, no, and probably no. And similar to another study, and after some deliberation, we decided to dichotomize the scale so that a definite yes response was coded as 1 and all other responses as 0, with a range of 0 to 6 and a study alpha of 0.75. So for the data analysis, for objective 1, we conducted gender-stratified univariable and multivariable logistic regression models by gender amongst the total sample. And for objective 2, amongst those who have ever had sex, we looked at the independent relationship between consistent condom use and high sexual self-efficacy by gender. So these are the characteristics of the samples. On the left is the total sample, and on the right is amongst those who've ever had sex. And in both groups, we see that adolescent women had significantly higher sexual self-efficacy compared to men. They also had higher HIV knowledge scores. Young men were more likely to say they'd ever have sex. As well, about 45% of those who have had sex said that they had 2 or more current girlfriends. And about a third of young women said their partner was 5 or more years older than themselves. Almost half of young men reported that they'd had difficulties in getting condoms. And despite these differences in concurrency, age-desperate relationships, and perceived access to condoms, we found that there was no significant difference in lifetime consistent condom use. And then I also just want to highlight the extremely high levels of experiences of violence in our participants, as well as about a third of all participants were determined as being probably depressed using the Center for Epidemiology Depression Score. Oops. So for men, the factors that were independently associated with high SSE included probable depression was inversely associated with high SSE, and then positive beliefs about sexual relationships was positively associated with high SSE. And then when we looked at the relationship between high SSE and consistent condom use for men, we found this was quite statistically significant, and experienced physical violence was also positively associated with consistent condom use and negatively associated with high SSE. For women, having higher HIV knowledge scores, more positive beliefs about condoms as well as sexual relationships, having an adult caregiver in the home were all associated with high SSE, and then experiencing physical violence in older age were both negatively associated with high SSE. And then the relationship between high SSE and consistent condom use for women at both the univariate and multivariable levels, we found this was not statistically significant, but experiencing depression or being probably depressed at older age were both negatively associated with consistent condom use for women. So what does this all mean? So sexual self-efficacy may be predictive of HIV preventative behavior for adolescent men, however they have lower levels of SSE compared to adolescent women. So really, there's a need to scale up efforts aimed at improving HIV knowledge and redressing harmful gender norms and negative sexual relationship beliefs amongst young men, as young men are and will continue to be the partners of young women who are disproportionately affected by the HIV epidemic. It is vital that we engage them in HIV prevention efforts at an early age. And for women, this work really aligns with another analysis that we did within this study that highlights this endemic of high trauma experiences, including violence, depression, and HIV risk for young women growing up in these settings such as Soweto. And in order to address this endemic risk amongst women, efforts are needed to move beyond some of these individual level determinants of behavior such as sexual self-efficacy, particularly as young women are reporting such high levels of age-desperate relationships where they likely have unequal power in their sexual relationships. Some of the limitations of this research include the fact that this construct of sexual self-efficacy, it relies on individual level decision-making, is based off of a Western construct. There were a number of factors that in this analysis that couldn't be included that I would have liked to because it was unavailable in the data, such as relationship control, intimacy, and intimate partner violence. And the sensitive natures of the question likely influenced participants' responses, and social desirability and gender bias probably played a role in that. And the cross-sectional design of the study did not allow for a causal link between high SSE and consistent condom use. But to conclude, for implications and moving forward, I think this research is really telling us that we need a diversity in HIV prevention mechanisms that move beyond male-controlled methods, such as the male condom, to allow young women more control within their sexual decision-making practices. And these new prevention tools that are promising, such as pre-exposure prophylactic, need to continue to acknowledge the social, structural, and relational dynamics of sexual decision-making, particularly for adolescent women. So I just want to say thank you to all the young people who have participated in this research, my funders, my committee members, and all of my international research partners, colleagues, and supports that I've had the opportunity to work with over the last couple years. So thank you very much. Is there a question?
We have time for one question. Maybe I can ask you a question. So, I think you've looked at the sort of gender relationships of some of these power practices and everything, but what about the power of having joint decision-making around some of these things?
Yeah, so that's another limitation, I guess, to this research, and I think it is a limitation amongst adolescent health research in general, is that we don't conduct research amongst couples, even though these decisions aren't being made by individuals in silos. Sex is between two people most often, and so I think this is an area that we need to look at. But again, it's challenging, especially if we look at the epidemic amongst young women, where we know that on average young women are being infected by partners 8 or more years older than themselves, that engaging those older male partners in research, I think, is an extreme barrier that we have. Yeah.
Thank you very much. Right. Well, our next panel member, Dorothy Shaw, needs very little introduction. I think she's known by almost everybody here. She's the Vice President of Medical Affairs at BC Women's Hospital, a professor in ONG and medical genetics, and has certainly been a huge advocate for global health at the Canadian Partnership for Women and Children's Health. Most recently, Dorothy has been appointed an officer of the Order of Canada, which is really amazing, and I think most of you know that. So today, Dorothy is going to talk to us a little bit about the drivers of maternity care. Thank you very much.
Thank you very much, Mark, and thank you, Laurie, in particular, for giving me this opportunity to speak about something I'm quite passionate about. And I'm just going to focus on one particular aspect of this, and that's the Lancet series on maternal health that came out. It was launched last September, and there were 6 papers, 27 authors, and lots of stories associated with what we learned. This was a second in the series. So the first one came out partway through the journey from the Millennium Development Goals beginning in 1990, ending in 2015. This one was really to tell us what progress had we made by 2015. And I was fortunate to be the lead author for one of the papers. And just go back for a minute, sorry. And actually one of my co-authors is in the room over there, K.S. Joseph. I was very fortunate with the team of authors on our particular paper. So I will try and keep this within my time, which will be a challenge. But there has been progress, is the good news, in reducing both maternal deaths and advancing maternal health care. And this paper, this series was only about maternal health. So there's nothing going to be said much about newborn. I won't be saying anything about mental health, even though that was a huge topic and had to be sidestepped. So it'll be really focused on that, and it won't be talking about family planning or abortion either. I know you know I'm fairly passionate about that too. By 2015, maternal mortality had decreased globally by about 44% from 1990, when so the maternal mortality ratio was 385 per 100,000 live births, decreased to 216. That still means that we have over 300,000 deaths per year, approximately, that's another issue, globally, that are potentially preventable. Now, we have about 3/4 of the women in the world delivering with a skilled birth attendant, and that's been primarily as a result of facility deliveries. So we're getting women to facilities to deliver. The quality of care that they receive when they reach those facilities is something that we could talk about for a longer period of time, and you can see the steep increases on that graph in terms of what happened with respect to the speed of getting women to deliver in facilities. 2/3 of women globally now receive at least 4 antenatal care visits. And here are the numbers for you. 210 million pregnancies a year globally, of which 140 million result in births. And then many morbidity episodes from those pregnancies from 5 key obstetric causes. What we've seen is a huge shift in terms of changing epidemiology and more diversity, divergence, and inequity. And here you can see something that I think is very interesting that is probably well known to many of you in the room. What's happened is that since 1990, when we started tracking for the Millennium Development Goals, when hemorrhage was the leading cause of death, and you can see the regions there that we looked at, the 4 regions. The high-income countries, the ones highlighted in yellow, because that's the group that the paper I was responsible for focused on. And so hemorrhage was our leading cause of death in high-income countries in 1990. And you can see that across the world, the percentage of deaths by these 2 causes, indirect deaths and hemorrhage, there's been a significant shift. So hemorrhage has decreased as a cause of death across the world. Indirect causes of death increased significantly. One of the papers that was by Sue Ellen Miller and colleagues was looking at something that we are all concerned about: appropriate, timely, evidence-based, respectful care. What did you find? Well, in many cases, women were receiving too little care too late and were delivering alone, and in other cases, too much too soon. And in some countries, women receive antibiotics routinely postpartum. That may be a surprise to you, but you might want to do the math in terms of how many of our women receive antibiotics throughout the pregnancy and postpartum. This is a topic that is well known to you as problematic, and that is country-specific cesarean section rates. And you can see on this slide that in low-income countries, over on the left of the graph, that cesarean section rates are still very low. And in middle-income countries, not high-income countries, in the blue circle on the right, we have rates as high as 60%. And of course, you know, in some private hospitals, it's even higher than that for cesarean section. Those are middle-income countries, okay? In the middle, you've got Canada is actually somewhere in the middle of that beige group. The list of women there that I'm not going to read to you are often left out of good quality care. And overall, 53 million women globally are not receiving childbirth care at all. In the focused paper on high-income countries, we selected 14 high-income countries, and we looked at what were the drivers in terms of maternity care in those high-income countries. And understanding that really data should be driving health system change. We looked at, you know, what do women actually want, looking at some of the studies on women's experience, and then the providers and drivers for change moving forward. One of the things, this is only taking some of the select countries so you can actually see more clearly, but the percentage of births to women over 35 years in high-income settings has actually increased steeply over the last 20 to 30 years. And Canada's in the middle of the pack. It's that purple color in the middle there. Spain, you can see, is approaching 35%. Japan's following rapidly. And in fact, in BC, we're further up that curve too. This is obviously concerning because the older women are at the time of birth, the more likely it is they're going to have some kind of underpinning medical condition. I'm not expecting you to try and interpret that graph. That just gives you the 14 countries, and KS can explain to you in the question period afterwards whether or not that line at the top, the red one for the US, is real in terms of them actually having an increase in maternal mortality, which you will have seen in some of the media reports last year. When we look at the causes of maternal death and whether that's changed, yes, there's been a decline overall. But there are marked differences both within high-income countries and between high-income countries. In the UK, over the last 10 years, we've seen a significant decrease, halving of direct obstetric causes, unchanged indirect causes. Cardiovascular disease, overall, the largest single cause of death for the UK, similar to the Australia and the US, and in fact in Canada. And morbidity, this was the conclusion from the paper, that really we need a team looking both pre-pregnancy, during pregnancy, and even after pregnancy for a multidisciplinary approach to care. One of the things that may surprise you that we learned is that substandard care in the confidential inquiries, and we don't have one of those, I'll say a little more about that in a moment, in the UK, France, and the Netherlands, showed that in fact substandard care was a significant underpinning related to 70% of direct deaths and 55% of indirect deaths in the UK, and also in France and the Netherlands. And you can improve that, and in fact France has done so. Inequities, also very important, and in the UK, mortality is highest among women living in most deprived areas and those women living outside the UK, born outside the UK. Interestingly, and just leaping to the third bullet there, but it relates to the second one, if you take a New York physician, black or African American, and you compare her with her white counterpart, she will have at least 2.5 times the risk of maternal death to the white counterpart. So it's not simply related to socioeconomic status. However, in Canada, we don't collect ethnicity data routinely, and while we were able to establish that yes, we have some ethnicity-related information that we could determine about higher rates of diabetes, obesity, alcohol, and tobacco use, that it was very difficult. In fact, overall, it was very difficult to get data for Canada. It proved to be a little embarrassing, to be perfectly frank. I couldn't tell you, and we still can't, to the best of my knowledge, how many birth centers there are in Canada. The data that we have for Canada is not rolled up nationally, and what data there is doesn't include Quebec. It's separate. In terms of the criteria that we're looking at, home birth rates, epidural rates, BMI information, ethnicity data, there are a number of things where it was actually very challenging. Overall, there are wide variations in costs, and you can see that between the 14 countries that we looked at, there's a significant delta between the cost of vaginal birth and cesarean section. Yes, malpractice costs are also high in North America, especially the US, actually in Australia too. And about half the countries had no-fault systems for infants that were born with serious neurological birth injury. What's interesting is that there is significant variability in practice. So high-income countries have variations that are not evidence-based nor attributable to facility size. And so we have significant work to do there. And you can see that one's on episiotomy that's circled. But we had a number of areas that we could look at. I'm just looking at the time. We looked at the best place to give birth. Is planned home birth safe? The answer to that question overall is yes, and I'd be happy to debate that with you in the question period. The best outcomes for the lowest cost we found to be, with the lowest interventions, are in countries where they have integrated midwifery-led care, team-based care in maternity hospitals, low-risk units along full-scope maternity hospitals, and freestanding and home-based midwifery. Quality of care, what do women want? I think that speaks for itself. This is very much aligned with Accreditation Canada. The role of fear is very important, and the voices of women, families, and broader civil society need to be a starting point and not an afterthought. Thank you very much. The list of the funding, the group, the steering group, and many of the authors are listed here. And thank you.
Dorothy, thank you very much. Do we have time for one question?
Hi, thank you, Dorothy, for your talk. A number of slides included the term women-centered care. We have some great organizations in BC that do that, like Oak Tree Clinic in my field of HIV. And I've written on the topic myself. And even for myself, it's quite elusive. And within our team, there's lots of discussions and debates about what is women-centered care and if and how it differs from patient-centered care. I wondered if you could share your thoughts on that.
Okay, so I think woman-centered care or woman-centered care is thought to be less maternalistic or paternalistic than patient-centered care, where the autonomy of the woman is not thought to be as prominent in the usage of the words. To the best of my knowledge, that's the main reason for the change in term. Accreditation Canada changed the nomenclature from patient-centered care to client-centered care. So again, it's trying to move away from the fact that patients are not necessarily viewed as completely autonomous in their decision-making. And are they completely autonomous? Well, obviously the informed consent process is a process. It's not a single point in time. And women do make choices with input from their care providers with the best information possible. Sometimes women make choices that are difficult for some of us to understand, but that's their right to make. As long as they are aware that those choices can be revisited with new information, then that's their right. I think that in terms of why have we gone that route as opposed to where we have been, historically, we have not been providing patient-centered care. It's a journey, and woman-centered care similarly. I think in clinics like Oak Tree, yes, we have really some very good shining examples of where we have really focused on woman-centered care. But overall, whether it's patient-centered or woman-centered, I think that we have much work to do still in terms of trying to ensure that we respect a woman's wishes and share with her all the information that she might need in order to make the best decision possible. Does that help?
Thank you very much, Dorothy. Right, so our last panelist, no means least for this session, is Angeli Rewat, who's a postdoctoral fellow in School of Population Health. For the last 15 years, Angeli's been working to strengthen health systems in low and middle-income countries and worked in many areas, including cancer care, HIV, maternal child health, and in many countries, Sub-Saharan Africa and in Asia. So Angeli is going to tell us a little bit about integrating healthcare systems. Thank you very much.
Hello, everybody. I'm going to take you on a little bit of a tour around the world and some of the places that I've been leading research projects in the past few years. So a little bit different of an approach than what we've seen, but a great foundation for what we've heard already today. So I think it's the green button. Nope. Okay. So as we have already figured out, women in low and middle income settings have complex health needs and multiple barriers to accessing health systems across their life course. So, these complex barriers could be anything from transportation to road networks to knowledge, awareness, community engagement. They have a triple burden of poor health in low and middle income countries, and that can be from reproductive and maternal health and to communicable diseases like HIV, as well as non-communicable diseases like hypertension, diabetes, and cancers, and mental health. So what I want to talk about a little bit today is how can health systems meet the changing needs of women? And when I say changing needs of women, I don't only mean as they change across their life course, but as the context, the country, the political situation, the environmental situation changes within their settings they live in. So I'm going to look at integrated service delivery as one way to examine this, as well as resilience during the time of shocks in a health system. So first, before I start, I just wanted to preface my conversation with what a health system is for those of you who are not familiar. Here's the WHO health system 6 building blocks that's often referenced, and there's lots of critiques of this model, but essentially you want, access to coverage and quality and safety and have improved health and social responsiveness, and that's the model that we're kind of working with in this discussion. So first, we're going to start our journey in South Africa, where I did my doctoral research. And what I wanted to know was, how does a health system cope with the integration of HIV care into primary health care clinics? So if you're familiar at all with the HIV response in Sub-Saharan Africa, it's been heavily vertical. And when they say vertical, that means it's a standalone program where donors came in with lots of money. It was an emergency situation, and we needed to get ARVs, the antiretrovirals or antiretroviral therapy, out to people as fast as we could. So we had specialized clinics with specially trained doctors and nurses and staff, but that just wasn't getting the numbers that we needed, especially in high contexts like in South Africa, which, as we heard earlier, has one of the highest rates of HIV infection in the world. So in 2010, the South African government decided to integrate all HIV care into the primary health care clinic, and that's what I researched. And so it was a 4-year-long study collecting quantitative and qualitative data of about 1.5 million people approximately in one province. So here's a schematic of the previous model of accessing care. So you can see that diagnosis would be done in the community level, at the base level. Then you'd go to the local clinic to confirm the results. You'd have to go to an assessment site to see if you were eligible, a treatment site to see to pick up your treatment. If you weren't eligible, you'd go back. So you can see there's lots of places for you to get lost or just not have the resources to come back. So in South Africa, there's 55 million people, about 7 of whom currently are living with HIV and AIDS. And as we heard earlier, women in the age of 15 to 25 years old are at higher risk of contracting HIV. So if you see the map at the bottom, that's where I did my research in the province in the orange, which is Free State Province, which has an adult HIV prevalence of around 20.4%, and the ANC prevalence is around 32%. So in 2010, they trained nurses to be able to, they did a 2-week program to be able to come in and actually, in existing primary healthcare facilities with no additional resources, they were able to prescribe and manage patients on care, which really decentralized access to ARVs. So if you look here, this schematic shows that at April 2009, a year before integration happened, there were about 1,600 patients on ARVs in the public sector clinics in my study. And by April 2013, that rose to over 57,000 patients on ARVs. So these were all patients who were in a separate system, now flowing back into the primary healthcare clinics where they had gotten their care otherwise. So you can see this dramatic increase in a very short amount of time. 77% of those, or about 44,000, were treatment naive, so they had never been on treatment before. So that's a great success. So what happened then for women's health when we look at integrated service delivery? It really allowed for healthcare workers to treat women holistically. Women don't see themselves as, this part of me has diabetes and this part of me, has HIV and this part of me has reproductive health needs, but they're an individual with complex needs. So it was less fragmentation than the previous programs, and healthcare workers said they were able to detect, treat, and manage comorbid conditions, especially for those with HIV and other diabetes, hypertension. Those were a great synergy happening. And they were able to promote family-centered care. So when there was a woman who, after she delivered, they would miss out on following up if she was taking her treatment. When she came in for the immunizations for the baby at 6 weeks or thereafter, they were able to catch them. As well as when there were women who were diagnosed with HIV, they could bring in their partners and their family and talk with them together. So that was a great advantage. And it really destigmatized HIV and really made it just part of the community and part of something normal that you would go to the clinic for. And some concerns that came up, as we've already heard about before a little bit, is quality of care. So with the increased complexity per visit, are nurses and practitioners able to cope with the multiple things they need to do for one patient? And we did see decreases in new hypertensives put on treatment, as well as immunization rates at 1 year. And so what are the spillover effects on the health system? There's still HIV exceptionalism going on, meaning the facilities and the government are still treating HIV as something very separate and unique, with unique funding requirements and reporting requirements. And there's definitely a need to identify the best practices in integrated care.